Welcome, everybody. Welcome to episode 3 in PEM Rules, the Pediatric Emergency Medicine podcast. Today, we're going to continue our discussion in PEM Rules in the group of clinical care, and we will specifically discuss some pediatric emergency rules that have to do with newborns. I see many newborns in the emergency department. Sometimes newborns, they're literally just a few hours old, born in a home birth somewhere. Those are my favorites. Newborns are kind of challenging for several reasons. Number one, obviously, for the obvious reasons, the parents are often very anxious. Sometimes it's fresh, first-time parents who have a lot of questions. And newborns are challenging for the obvious reasons. They can't really say much at all, and they can't really complain. They can't tell you where it hurts and what they feel, and you often kind of rely on history of a parent, which is obviously very subjective. To my understanding, there are even studies published about the lack of reliability of physical exam in the newborn period, and I can see why that is. So often I do a full septic workup on a child that has no symptoms other than a fever, and the spinal tap comes back positive for gram-positive cocci or some other horrible organism, and all the kid had was a fever. He looked fine otherwise. So it's probably true to some degree that just physical exam is not reliable in that age. The baby is crying, you can't hear the lungs because he's crying, you can't feel the pulses because he's crying, you can't feel the abdomen, and round we go. The following PEM rules that I'm going to discuss specifically have to do with newborns. Rule number 6, the white rule. This is something I tell parents all the time. Babies, newborns are only allowed to vomit or spit up white stuff. Never bloody, never green. Spitting off and vomiting is a very, very common chief complaint in the pediatric emergency department, and I often find myself providing reassurance for those parents and sending the child home. The most important question I find to ask is the vomit white or whitish? To me, that is the most important reassuring sign. Anything bloody or anything bilious/green makes me a bit worried. Of course, there are exceptions. If mom is breastfeeding and telling me that she's bleeding from the nipples, that's okay. The patient is allowed to have some mild bloody emesis. Of course, the physical exam is to be reassuring, the vital signs, etc., and I may send the child home. I can't think of a similar situation where bilious emesis will be normal, so by definition, bilious emesis makes me more worried. I often tell parents about the white rule. Rule number 7. Rule number 7 is actually the rule of 6. I see a lot of patients in the pediatric emergency department with complaints of vomiting, and I think it's often very important to remember what could this represent worst case scenario. And worst case scenario really depends on the age. So if I see a baby that is 6 minutes old, just came out, unlikely in the pediatric emergency department, but let's say I did, who's maybe not vomiting a lot, but drooling. I think of tracheoesophageal fistula with esophageal atresia. Those patients often drool a lot because the drool has nowhere to go. If the patient is 6 hours old with bilious emesis, especially if he has trisomy 21, I think of duodenal atresia. In a patient that is 6 days old, vomiting a lot, potentially surgical abdomen not particularly well appearing, I think of malrotation with valvulus. 50% of those patients will present in the first week of life, so 6 days sounds about right. In a patient that is 6 weeks old with projectile emesis, obviously everybody knows that's pyloric stenosis, the classic firstborn male. In a 6 months old who's vomiting a lot, has intermittent pain, maybe drawing his knees to his chest, I think of intussusception and I get an ultrasound. And obviously everybody knows in a patient that is 6 years old with a surgical abdomen, vomiting a lot, most likely need to rule out appendicitis. So that's rule number 7, which is really the rule of 6. Rule number 8, I know it's confusing, is actually the rule of 7. 7 bowel movements a day or no bowel movements for 7 days in a newborn, that's okay, as long as you have a normal physical exam and, again, the white rule is not violated. Almost every shift I see newborns who come into the pediatric emergency department with the chief complaint of constipation by the parents. I often explain to parents and reassure them that in a baby, 7 poops a day or no poop for 7 days is totally fine as long as the patient is not vomiting blood, vomiting green, and he's growing. We'll talk about that in a little bit. I gotta admit that one of my colleagues, who I think very highly of, is probably a little bit braver than I am, and she has actually the rule of 10. 10 poops a day or no poop for 10 days, if the child is well appearing, she sends them home. Going back to our previous episodes, I want to remind you about less is more. If mom comes to the emergency department with a well appearing newborn who hasn't stooled in 4 days, the less you do, the better. That leads me to rule number 9. The single most important indicator that a child or a newborn is healthy is weight gain. I see many patients in the pediatric emergency department with chronic complaints of some sorts. Most commonly, the mom would say, "Oh, doctor, my child always has a runny nose. He always gets a fever. He misses tons of school. I'm really worried about his immune system." I often remind to those parents that kids with immunodeficiency or some other serious chronic problems, they often don't grow, don't thrive. Those are not average normal kids. A child that is totally fine and gets 10 colds every year is normal. Another good example is abdominal pain. Sometimes I see patients in the pediatric emergency department with chief complaint of abdominal pain for 4 months. Exam is always normal, no other red flags. I always reassure the parents that abdominal pain for so many months and the kid is doing fine otherwise, not vomiting blood, not vomiting green, and gaining weight is very reassuring. It's obviously not a surgical abdomen, unlikely to be Crohn's disease or ulcerative colitis or anything else serious given the normal growth. So the single most important indicator that a child is healthy is weight gain. Obviously, in a newborn, you should never accept any weight loss or lack of weight gain. That's by definition failure to thrive, and those kids deserve a workup. Another good example is when I see a child with tachypnea, respiratory distress, without any viral-like symptoms, rhinorrhea, low-grade fever, etc. Sometimes I do worry about congenital heart disease. I immediately look in the growth chart and I see if there's any weight gain. I think it's important to keep in mind that kids with congenital heart disease, again, they don't grow, they don't thrive, they don't gain weight particularly well. Rule number 10, a feed is like a stress test for a baby. When I worry about congenital heart disease, such if the patient or the newborn has failure to thrive, frequent respiratory issues, or an exam I hear wheezing without viral symptoms or murmurs, and I'm worried about congenital heart disease, I think it is a good idea to ask the mom, how does the baby seem to be when they're feeding? Keeping in mind that feeding for a baby, especially breastfeeding, is hard work. I asked the mom, does the baby seem to be sweating or struggling during feeds? Feeding well is a very reassuring sign that strongly speaks against any congenital heart disease. I also discussed that with the parents to provide them reassurance. Now, having said all of those rules, I think it's really important to remember rule number 11. Newborns are black boxes. I often find myself doing quite a lot more studies than I would do on an older patient. I think it's very important to be as conservative as you need in newborns. My general rule is to be very conservative with newborns since they are a bit more fragile. Again, they tend to get worse pretty quickly. They obviously do not have a lot of reserve. A lot of times, those parents need a lot of reassurance that I just can't fulfill with my history and physical. So I certainly think it's reasonable to obtain some labs or maybe get a chest x-ray to reassure parents of newborns. Really, it has been found, to my understanding, in many, many studies that physical exam in newborns is very limited. I often can't hear the lungs because the patient is crying. You can't feel the abdomen because the patient is crying. So in my mind, it's very reasonable to rely on testing in that age group. So keep in mind, rule number 11, newborns are black boxes. Be as conservative as you need. And that's it for today. Those are our pediatric emergency rules for newborns. Again, just to recap, rule number 6, the white rule. Babies are only allowed to vomit white stuff. Rule number 7 is the rule of 6, which helps you remember the serious causes of vomiting based on certain ages. Rule number 7, 7 bowel movements a day or no bowel movement for 7 days is normal in a newborn as long as the white rule is not violated and the patient is growing. Rule number 9, the single most important indicator that a child or a newborn is healthy is weight gain. Look for that weight gain in the growth chart or simply ask the parent. Rule number 10, a feed is like a stress test for a baby. Any baby that seems to be struggling with feeds has congenital heart disease until proven otherwise. Rule number 11, that summarizes it all. Newborns are black boxes. Be as conservative as you need. certainly okay to rely on some labs or imaging in order to guarantee the patient does not have any serious condition. And that is it for today. Thank you for listening to episode 3, Pediatric Emergency Rules that have to do with clinical care tips for newborns. Hope you enjoyed it. See you next time.